Our next speaker is Dr. David Talbin.
We're ready to go?
We are
Good.
ready to go.
Thank you. And that couldn't have been a better prelude to what I'm going to talk about, because Dora just communicated so eloquently with her personal story, talking about the narrative and the family background, and said it in such a poetic way. I'm going to just find it very difficult, because I'm now going to bore you with some of the science that's behind that, but really is perfectly supported. And I was mentioning to my colleague here, Dave Hanscom, who's coming up at the end of the day, that it's a tough act to follow, and we're also talking to the same message. So the consistency, and I want to thank Robin and the team who put this together. I don't think we're going to hear too much disagreement, so hopefully we won't be terribly boring in the process. So just by disclosures, because this is a continuing education program, we have some grant support, but nothing that will do anything but enable me through my work at the university to be able to communicate as effectively as I can. So again, for CEU, I'm going to review the neurobiological as described as a lived experience, the psychological and social mechanisms that are involved in the experience of pain. Talk about the modern assessment strategies, which we rarely do now, what we should do to be able to explore those domains and to be comprehensive and the full life experience from our patients in our electronic health record-driven world these days. And then, importantly, because of an advocacy perspective, identify both individual, but more importantly, the system barriers that prevent us from really doing the right thing. So this is a borrowed slide from a Stanford colleague. This is a map of the domains that affect people when they have pain. And this is not, we will give you the quiz afterwards, and if you get anything wrong, you won't get your CEU. But this is just I think, an honest description of the number of things that people bring to the exam room. And to tease through this process is enormously difficult. Because I'm going to talk a bit about the systems that are involved in this, and I'm going to revert back to this repeatedly, is my best approach at identifying the challenges that we have in terms of system delivery, design, communication. We heard a lot about how difficult the communication is, bias, stigma, disparities, working as a team, because pain is not possible to be done by a solo practitioner. Pain engagement, self-management challenges, community resources, which are limited, organizational policies, which make it even more difficult to deliver effective pain care, health information systems, which is the bane of many of our existence, because if we're trying to take the patient's story and the electronic health record is telling us the story we have to take, they are in such dyssynchrony that we have to just push that aside and ignore what drives the health system. And then the financial and physical access to resources. So I don't think this is a strange topic, but we have to confront all this as the barriers, oops, wrong button, for managing. We mention of opiates already made. So what happened that led us down this track? Well, it was a recognition, frankly, that pain was being ignored. If you had severe intractable pain and didn't have the stuff that some folks do have to bring to be able to look past the pain entirely, that we needed to be more enlightened and provide opioids for individuals if they had severe pain. And you didn't have to be dying of cancer to have pain, was this common story. So I actually, mea culpa, I was part of the writing of this permissive law, so I know the story from back to over 25 years ago when this law passed. This passed every single state over the next couple of years, and the key domains here that are problematic. First, you're not going to lose your medical license based solely on the quantity and or frequency of opiates prescribed. That was the problem. There is an issue about quantity frequency. We did not recognize that, and if you read today's paper, or yesterday's, or tomorrow's, you're going to hear about the legal settlements and the hundreds of thousands of people who've been damaged by opioids. The over-reliance on opioids, just to reset the stage, it's the third largest epidemic in the history of the United States in terms of deaths. It's preceded by the influenza pandemic of 1918, 500,000 people lost their lives. HIV 500,000 in that interval. And opiate prescription overdoses now at 165,000 lost their lives as a result of the prescription side. We're not talking about people who are misusing the overall illicit. So it's an enormous problem. It affects the entire country. And top left corner, I think it's because we don't manage pain properly and we resort to opioids as the move number one. This paradigm shift became evident in the early 2000s. Myself, others, one of my colleagues, Dane Ballantyne at University of Washington in 2003, published this, one of those epiphanies. By the way, I had an epiphany as I did philosophy, and a Hungarian philosophy professor. Thank you. Miklos Vetu. I still remember his name. I was sitting in a room, and I had this epiphany. So a similar epiphany was reading that work, 2003, that basically stated, what are we doing? We really don't understand this opioid issue properly, and it's time to change. So this took a while, about 13 years before it became recognized that, published in the Annals of Internal Medicine years later, the effectiveness and risks of long-term opiate therapy for chronic pain doesn't work. And the paradigm clearly shifted, even though certainly many of us in the room here are already recognizing that not only clinicians and health systems, but patients and families, we have to take a completely fresh look. In the state of Washington, we're actually led the nation. Those in the room here may not recognize it, but the first guidelines that came out to describe the problem with opioids were generated by a consortium of private practice individuals. I was in that system at the time, academics, health policy considerations, the state agency. It was a heroic effort to push out some guidelines that suggested that unlimited opioids is really not a good idea, and we got to look at the whole person and treat with non-drugs. Interesting, I know there's a couple lawyers in the room, but no offense, but I was actually sued by health advocates, and the agencies were sued for depriving people of the rights to get opioids. And it was dismissed, fortunately, at that time. But that was the amount of energy that was driving the fact that we needed to continue to use these. But you can see our first guidelines came out in 2007. We didn't think it had any effect at all because it takes a while to collect data. It takes a year or two to collect the data. They became a rule, and you can see there was a clear decline. That was the first state that did this. But the problem we had was, if not opioids, what then? If we're taught that it's only about giving opioids to patients to relieve pain, we need to give other things, but there was no system in place to deliver that. Who's going to pay? I don't think, does health care pay for yoga classes? Not yet. Should it? Absolutely. Does health care pay for the psychological support? Yes, but not if you're on Medicaid. And does it pay for psychological support if you've been an injured worker at the time? It doesn't matter at all. They will not cover psychological support. So I can go down a long list of the kinds of treatments that we could not get access to. Many of those things are changing now, and it's because of the advocacy of the public, health systems. Everyone in the room here are contributing to the ability to make this change. Because this is a bottom-up event that's taking place. This is not, it's not been coming from top down. So the Centers for Disease Control came out with some guidelines for prescribing opiates in 2016. I'm proud to say that they basically plagiarized our Washington State guidelines, which is fine. We like it when it goes big. And they kind of outline the overall process. They make mention of the needs for other things to be done, but there's no mechanism to deliver any of the things that they say you have to do. So the clinicians are in the conundrum now of we should be prescribing opiates, we have restrictions on them, this all makes sense, so what are we going to do for our patients? So that's one of the major barriers, is access to the kind of services that you're going to hear about that is going to come through health insurance. Now, folks who can afford it themselves can manage, but the economic issues that are facing so many Americans about even paying for basic health care have a major obstacle to beginning to receive other overall care. One of the things that was clearly published in the CDC guidelines, and I want to highlight this, this is the fine print. I have a slide of this for another lecture that I take the whole section and I shrink it down, and you obviously can't even read it because it is truly fine print. But I want you to be able to identify tapering opioids, which is what we're now doing, is especially challenging. Be non-judgmental, involve the patient in the opportunity to personally reevaluate this. Be empathic, review with the patient-centered, working with the patient, go slow. And if you pull away opioids, you may unmask a whole host of problems, including anxiety, depression, and even opiate use disorder in the overall process. This has been a major problem because no one reads the fine print. Health systems are saying we are not prescribing opioids, and if we don't prescribe opioids, we're not doing pain care. And the signs have gone up all over the United States and in Washington State that we don't take care of pain, because pain equals opiates, opiates equal trouble, and therefore pain is trouble. 10 years ago when I started university, taught medical students, I had a fourth-year class, and I said, at the end of the class, they were in the clinic with me, I asked them, what did you learn? I'm just starting this curriculum. And the first thing that the next 12 students in a row said, these pain patients, which is a little derogatory, but these pain patients are really nice. Yeah, well, you know what? I still say it, and the hair goes up in the back of my neck, because they've learned, if they're 4 years of education at a pretty progressive school, UW is one of the top schools around, that these are really not nice people. And the other thing they learned was that there's something you can do. So is there a deficit in medical education? Yes. In fact, the average education of physicians in the United States on pain is about 4 hours in 4 years. Nurses do a bit better. There's some variation in that. Canadians are a bit better. I'm happy to say this afternoon I'm doing the second of a 4-hour course. We're at 8 hours at UW, Gabe. But I used to have a full head of hair before I fought with the curriculum committee about this, because it is a battle to get into curriculum. There's so much to learn and so much to know that something that's as complex and so non-scientific sounding is not something that is literally put on the curriculum list of importance. In fact, pain is not even on the global burden of disease. Pain represents 82% of the global burden of disease conditions, but because pain is not recognized as a disorder, it's not on the global burden of disease, and medical schools teach to the boards, and pain is not on the boards, and medical students teach to the global burden of disease. And so we struck out twice, so it's been a very arduous battle getting on curriculum. So new evidence supports a major shift in practice. One of the biggest problems, the indication for opioids is confusing. Dose and duration we heard about, risks of opioids compared to risks of other treatments, need to measure and track outcomes. And then the key is after an acute traumatic injury, it's completely appropriate to use opioids, but when do you stop? How do you bring it down? And how do you provide other overall alternatives? And properly understanding the CDC guidelines is critically important. And there's a major effort now to communicate CDC guideline to our clinicians who are struggling because their systems don't provide them access to the tools they need. It's more or less like going in to see a cardiologist with chest pain and having no blood pressure, no chest x-ray, no EKG, and 10 minutes to solve the problem. You're not going to get good care at all, and that's the current system structure. So there's been some work on identifying that there's no shortcuts to safer opiate prescribing. The CDC people are really working hard to educate this. But the good news is, hot off the press, this is October 10th. Finally, HHS came out with tapering guidelines and a strategy to support taper. And lo and behold, they recommend all the things that you're going to learn about today. Because they certainly do recognize that if not opiates, what then? Well, you need to get into the mind, into the spirit, into the culture, into the communication, the stuff that Dora discussed so eloquently before, and you'll hear about later. They explicit. So I spent 2 hours on a call yesterday asking So who's going to pay for these services? How are we going to communicate to the patients? And it's like, I don't know. Someone's going to have to figure out how to do that. So we have another system barrier, being, again, access, financial access, and communication access to systems to manage this. So the challenge, again, is how in the face of all this can we maintain compassion so we don't hear students now saying these pain patients are shockingly so nice when we start from the premise that these are human beings. We don't decide who deserves care. The problem is pain is something we don't see. We're told, and so people with different skin colors, different accents, different backgrounds get very different pain care. This is well documented in medical literature. Long bone fractures, if you happen to have black skin, you get 20% of the dose of an opioid in an emergency department. For a broken femur, we have an orthopedic surgeon, that hurts, doesn't it, a broken femur? And it's said that African Americans have a higher pain threshold. So I said, where is that from? So you review the literature. The reason is because African Americans don't report pain when they get health care, because if they say they hurt, they're going to be called addicts and don't get any care at all. So if you untangle the social dialogue and the network that's just behind that, we can recognize that this compassion is sorely missing. So just a few words on the difficulty of the conversations that we have as clinicians. There's been a lot of my colleagues who I can credit subsequently. It's an unsettling conversation for patients talking about pain. It speaks to their vulnerabilities. It speaks to the story of their life. It's very difficult to talk about traumas. It's hard for us to be in a room with someone suffering and not have an immediate way to eliminate that. I'm in the Department of Anesthesia as well as internal medicine, and the anesthesiologists, I joke, it's really easy. They just say, good night, and they... But you give a little opioid and benzodiazepines and sedative, you just say good night, and that had been the previous strategy. You don't want to be in a room with someone suffering. It's really difficult. And we need to feel it, we need to acknowledge it, and we need to gain the skills as clinicians to be able to overcome that and create our own boundaries, our own mindfulness moments that we have with our patients that allow us to participate in these difficult conversations and not be and still maintain our professional objectivity. Patients have a lot of concerning behaviors. I have a quick list of this. I won't read this, but there's a lot of challenges with people who are struggling with moving forward with their lives. And there's clinics that fire patients just if you do any one of these things, because these are just hard patients. They take a lot of time, a lot of effort, and we regular report, you fire the drug, you don't fire the patient, but that's hard to communicate, especially with top-down leadership in many clinics. Happy to be rid of these people because they are more challenging and take more time. The average time that a primary care physician has to communicate pain, this is a few years old and I'm sure it hasn't gotten any better, is less than 7 minutes. And so to talk about all this and communicate all about this in 7 minutes, they have 9 other screening measures for health preventative maintenance, and they, at the end of the day, spend an hour and a half navigating the electronic health record. So they ain't got no time for pain. That's Carly Stevens, I think, from a couple of decades ago. There's an interesting, no time for pain, because it is challenging. It's a complicated disorder. So we teach motivational interviewing to our patients, and this is one of the most important things that I think I do with, in my clinic working with individual trainees. The first thing is, what you're doing now really going okay? Joe Merrill, who taught me this, is, so how's it going on the opioids and the benzos? How's it going spending your whole day disabled, miserable, in bed, not moving? You can ask those questions. The patients will say something back, and you therefore can identify that the status quo is not acceptable. That's standard technique originally with alcohol training, but it is really important in pain. So how's it going for you with what you're doing right now? And then is change possible? And then you need to set goals for change. You have to pace. We heard about that earlier, being able to pace yourself to meet those goals. And what are those specific obstacles to overcome? And then coach. Yes, you've done it. You've been able to get out of bed once today.
Oh, it's so fantastic. You couldn't do that last time. It seems patronizing when I say it to this group right now, but it is so important to continue to recognize and acknowledge any small step that's made forward. That's basic motivational interviewing skills. We do better job teaching our students this now, but it's time consuming. It's much more interesting talking about the electrolyte transmission through the glomerulus, and that's way more time spent on the curriculum. There's 110 hours teaching about hypertension. That's great, and 4 hours about pain. It seems like we missed the point. The number one reason people see clinicians of all kinds is because it hurts. And where that hurt is coming from, maybe it's in the back, maybe it's in the heart, maybe it's in the mind and spirit. That's a lot harder to be able to accomplish. And the systems have behaviors too. Pain is stigmatized, addiction is stigmatized. Even when addiction is not present, pain is still stigmatized. It's a production-driven model. I was talking with Dr. Stanos, and I have the same. I was over at Swedish, struggling, convincing the administration that we are indeed not losing money when we run a pain service that provides multidisciplinary pain care. A comment by one of my colleagues is we're valued based on RVUs per square foot, which is, in other words, how much dollars we can generate based on the square footage that the institution's covering. This is standard health system practices. Procedural interventions are very profitable. Procedures that we do in pain clinics and procedures that our colleagues in the operating room do. That's what makes money for health systems. So there's a huge pressure to do stuff. I don't get any pressure to spend more time with my patient and listen to them. I've never had an administrator say, you know, Tauben, you're just not spending enough time with your patient. You need to spend an hour with this person who's really struggling. It just hasn't happened yet. I'm waiting for that. And then the electronic health record, which I think is very important and very useful, but it's a scourge on the narrative. You just cannot have a conversation when you're clicking boxes. It's just not possible. I don't know of any way around that. Maybe scribes will help, but we're not sure. So the law, my clinic, the CDC is making me do this, so we cop out, we blame it on someone else rather than owning the overall problem. Patients are responding back. I don't want to read this to you for the sake of time, but I got a couple other topics. But I'm not an addict. I've done everything you've asked me to do. I wish you could feel my pain. Do you want me to lose my job, my family, my life? I'll just have to kill myself if you don't care. These are tough. These are tough interactions for clinicians. And we need the language and ability to overall respond. And this is hard to get into training, and it's just hard for people to do. So we also need to have shared goals. We heard a willingness to be able to be uncomfortable ourselves, and for the patients to acknowledge that having this sensation doesn't have to ruin your life. In fact, this may be a way to move forward with your life and gain some additional personal courage and power. Acting in service of your values, and our values as healers is to persist. We have to act it, and we have to do it, and we have to be advocates for that whole process. And we have to believe that this process will work. So we have to bring that into our clinic visits, and we have to bring that to all our health systems so they truly believe that. And then finally, having realistic expectations. So what then is pain? I'm going to just do a quick summary. My mentor, John Lozier, produced this concentric circles. I've named it an onion. I like the term for onion. It was my wife she was a great cook, and she was cooking up onions, and we were both crying when we were cutting them together, and then we put them in the saucepan and slowly heated them up. Took really good care of those onions so they caramelized beautifully, and that tears turns to sweetness at the end of it. So if we understand what our patients are going through, we understand pain, we can turn that awful pain patient into actually someone we admire, and if we can show that admiration and our respect for that patient, our healing techniques actually work. It's tremendously effective to create that empathic relationship. So pain is an unpleasant sensory and emotional experience. It's an emotional experience. There's no doubt about it. The mind is involved in the emotional experience. Actual damage or just the thought of damage. We have imaging that now shows thinking about pain activates your pain centers. And if you're thinking about pain and then you stimulate a person who's thinking about pain, that stimulus is experienced at a heightened intensity. Surprise, surprise, that really makes sense. And we heard Dora mention that before. Again, but this has been well established. This is 30 years old, this model. This is nothing new, but we're still struggling with that. Then there's the sensation. It's called nociception. That's just the signal going in, but that is not pain. The suffering that people have is what I think we need to focus more on, even though there's sensations that are coming from the periphery. It's a diminishment of one's capacity. So if pain keeps you from having the life you need to have to fulfill your goals and sense of personal contribution to the world, if pain prevents you from accomplishing that, you're going to have to take care of that, not the pain. Speaking of Holocaust issues, Viktor Frankl's great work about man's search for meaning, it's women's search for meaning as well, but man's search for meaning talks about prisoners who fail to watch the setting sun at the end of a day. You know, they're barefoot because they can't fit their feet into the shoes. It's sub-zero building Nazi railroads. It's not a happy time. But those who looked up at the setting sun, he noticed, lived. And if someone looked up and then stopped looking up, they died. And so it's just a sense of something bigger than yourself that's more important than your own individual personal narcissism, as we heard earlier, that's involved. If it's something bigger than you and you have a purpose for that, you can gain that possibility to overcome your pain, because that's meaningfulness and purposefulness. And if you do nothing at all and you're completely dependent on everyone to take care of you, I don't know how you're going to find meaningfulness and purposefulness. It's not part of human attitudes. And then the behavior is what we decide the patient's doing based on how they look. So there's all sorts of concerning behaviors, but that confounds the issue because we can't see pain. So pain has been around a long time, obviously. Humans grew up with it. It's very important. It protects us. But it was not really understood where it came from. So for many eons, it was thought to be evil spirits because it felt different than another sensation, unlike vision and hearing and taste. It's a very, very different sensation. Also thought to be divine punishment for sins we've committed. So there's a guilt and a sense of you've done something wrong and you deserve it, and therefore it's your fault. So it's a complicated spiritual complexity. And then sorting it out medically, it was an imbalance of the four humors, so different health systems. This is Western version. Indigenous Americans have another system of where pain fits, and we're working with learning about that because they actually have done a really good job at explaining pain and approaching it without drugs and other healing methods. It's not part of your session today. We're going to have a spiritual healer at a conference in November that we're running to begin to have this dialogue a bit further. So the first scientific description of this was Descartes. You can see this goes back, hundreds of years. The first question is why this boy's putting his foot in the fire. That was never answered. But he basically said there's a pipeline going to the brain, so this pain is in the brain. That was a breakthrough that this was discovered. It was a fluid pipe, which is not correct, and it went to the pineal gland. So it didn't quite get the parts correct. But this at least embodied the pain experience into the individual. But we also have evidence. So what's wrong with this picture right now? Yeah, this guy's using his severed leg as a club. Is he having pain? No. Why is he not having pain? Because wants to survive. He wants to be a hero. He wants to get health benefits from the VA system in Persia. I mean, there's all sorts of things going on in this guy's mind. It's likely survival, but and the valor of victory and his nation and the courage that he's showing and all that. There is no pain in this picture. This is the 16th century. It was again described in the Second World War by Henry Beecher. Fully 30% of severely injured casualties, American casualties. No pain complaints for 72 hours when their guts were blown out of their body, their bones were smashed. No pain complaints. So when I asked the students this Tuesday, it's adrenaline, they said. The answer is no, it's not adrenal. It is the complicated brain mechanisms that we have in place that define what's important. Pain that's important, we pay attention to. Pain is not important when you're trying to survive or you're watching your fellow soldiers being blown to bits. Your pain is no longer important. So adding something more important back to the individual's life is what makes the overall difference. So we do a bunch of cool stuff in science right now. Snow World was introduced at Harvard Medical Center about 25, 30 years ago. In the burn unit, where the poor people who severely burned have to endure a scrubbing of the eroded skin, and it was so severe, the pain, they were given a general anesthetic. And a general anesthetic every day for weeks is not good for the brain. It's also very expensive for the health system to put that system. So they introduced a virtual reality. This is the first video game in the history of IT, and it was Snow World, and we observed that a 40% reduction in requirement for opiates and sedatives in people who were doing something else. And they picked snow to contrast the hot of the burn. But there's lots of other particular strategies. In phantom limb, we give the brain something else other than the absence of a limb. We give them the presence of a limb. And this is a mirror therapy, so movement of a hand that you don't have, but it looks like you have, tricks the brain into extinguishing. Nature abhors a vacuum. A vacuum of a sensation is replaced by another sensation. That's who has tinnitus around here? A lot of us may have tinnitus. Tinnitus is not an active state. Tinnitus is an absence of hearing, and the brain puts sound back into our head. Phantom limb is very much the same. And if you have an absence of meaning and purpose in your life, the brain will fill in another sensation, and it often is pain. Because no meaning and purpose in your life, social isolation is painful. So it's actually not a surprise. And then there's a cool app for that Lorimer Moseley's done for a couple of painful conditions, where individuals, if they just recognize, right, is this a left hand or a right hand? Is this a left hand or a right hand? And they have different images. If you go through this really quickly, you can train your brain to not have pain in an affected extremity. This is graded motor imagery. Lots of interesting stuff that has nothing to do with drugs. It's replacing an absence. And I'm going to go back to the Lozier diagram again, and I'm going to say it's the suffering component of pain, because pain is inevitable. Has anyone in this room not had pain? Okay. If you did not have pain, you would not survive past adolescence, because some children are born without pain sensation, and they break their bones, they bite their tongue, they have huge ulcers on their skin. It is an incredibly important system. So having pain is normal. As we heard, being pain-free is abnormal, and actually we know diabetics have ulcers, spinal cord injury folks have huge decubiti. There's an enormous amount of health consequences about not having particular pain. So this, in the neuroscience field, Karen Davis has done some really interesting work. I'm just going to summarize this complicated slide. I'm mostly putting up this just to let you know that we scientists are actually sort of working on this right now. But she identifies an attention pain network and a mind-wandering network. So mind-wandering is what we try to achieve in the yogic state or an MBSR. And she puts people in a functional MRI and sees whether the brain is naturally in a mind-wandering state or the salient state where something is important. And we naturally mind wander, and if you're laying in a functional MRI for an hour, your mind's going to wander, and then all of a sudden it's going to sort of alert itself, what am I doing in this? So she's following the functional MRI patterns of what's happening in the brain. And when people are in the salient network, they're paying attention, they're given the exact same stimulus as when they're in the mind-wandering state. And the patient clicks, the study subject clicks what's more painful, and surprise, surprise, even if you're not paying attention to pain, but you're just paying attention, the pain hurts more. So we kind of understand now what this mindfulness-based stress reduction is aiming for, the yogic state, the deep breathing. The deep breathing I do before I go into an exam room and I'm running an hour late, and this patient is unbelievably complicated, and the nurse says, take a deep breath before you go in there. And I do that, and that gets me ready for, that's being prepared for the visit and makes me actually a better clinician at it. So it's been sorted out. Between this is
extremely, and then on the right is the descending inhibitory pain pathway. I told the students just yesterday, I said the only thing you need to know is the descending inhibitory pain system, because the body's pain system is on full on. That's the default mode, full on. We're driving our vehicle, our taxi cab for our mind and lives, with the pedal to the metal. And we control pain with the brakes. And a normally functioning pain system, you're riding the brakes. And you have control over those brakes. We can offer patients systems that can control those brakes. But if you let those brakes off, all these things are going to hurt that don't need to hurt. So it's the system that we need, and it's the descending inhibitory modulatory system. And if you want to guess, the best way to destroy the descending inhibitory pain pathways is opioids. The other is not moving. The other is being anxious and depressed and hopeless. Not sleeping. Are these common symptoms in our patients who are struggling? It's all about the descending inhibitory system. I said, if you ever see that word in an exam, check the box if it has to do with pain, because even if you don't understand the question, it's probably the right answer. We also know that social isolation, again, we heard a great comment by Dora about this earlier, that if you're disengaged from society, from family, from community, you hurt. This has been demonstrated with functional MRI, and lots of work's been done in this area. They do it with, again, a brain scan going, and you're playing a game, and people are bouncing balls, and you, the avatar on the computer, is getting the ball a lot. Hey, I'm pretty popular. Everyone's throwing me the ball. It's so silly, but it's amazing that it works, because pretty soon people stop throwing the ball. Pretty soon everyone's playing the game, and you're not included. The pain system activates. Now, why? We are social creatures. If we are not part, when we're little, if we're not part of, with our parents, we freak out. If we get teenagers, if they're not part of the social group, adults. So social isolation drives the pain system. So when you have pain, you are naturally socially isolated if you can't get out of your bed all day. If you're not working, if you can't engage in family activities, you can't engage in community activities, you can't be with your friends. Another system that needs to be focused on, and this isn't going to come from a pill bottle, that's for sure. Because opioids, for instance, I'll pick on opioids here, interfere with oxytocin. Looking at an OBGYN, she understands this quite nicely. And oxytocin is the bonding hormone. So if you want to suppress social bonding, give opioids. It's perfect track. Now that's a smart thing to do long term when the systems need to be actually interacting. We heard a bit about trauma earlier. I want to just reinforce this. These are the ACEs, Adverse Childhood Experiences. I'm not going to have time to go through them in great detail. This is bad stuff that happens to people. 30% of the patients who report to our clinic have post-traumatic stress disorder by screening tools that we use. And I'm not at a VA clinic. This is life, often early childhood, early life experiences change the way the brain responds. Imagine the pain is the threat detection system to our bodily safety. It's a protectometer. Imagine if you go through early childhood with violence in the home, sexual assault going on in the background, addiction, alcoholism, all those nasty things on the left happening. You are on alert. Your threat alarm is broken. It's on full time, and then you put any sensation into that system, you're going to have pain. And we've demonstrated that. Recent work by one of my colleagues, Dale Langford, looked at the data points, and people who have a lot of these things going on, certainly PTSD, report higher pain domains at every measure we take. We look at pain intensity, we look at disability function, we look at quality of life by all these fancy tools. It's about 80 questionnaire. Every single domain goes up, and each one you add, just like Bob Anders' work, each one you add. So we're trying to put chronic pain on this list because it is overlooked, and we start with the assumption that there's been some trauma, not just a physical trauma. But 2 spine surgeries don't work. PTSD is evident. Returning back for any surgical procedure because the first one didn't work is a 10% incidence of PTSD. ICU stay any time where there's an overwhelming threat to your personal identity. Definition of PTSD, overwhelming threat to your personal identity. You are at high risk
of developing pain. And I think if we reflect on the patients that we see and individuals who struggle with pain, they've had plenty of threats to their personal identity along life's course. And then we add the novel concept of the pair of ACEs. It's a nice way of recalling it. So adverse community environments. This has been a lot of good work done. Nadine Burke-Harris has a great book called the Deepest Well, is what she calls it. She's now, by the way, the Surgeon General for the state of California. It's a novel idea of a Surgeon General in the state. And because of her advocacy for childhood-safe environments in the community she was working and addressing all this, the state of California decided that it was a good idea to recognize the work. So changing the community environments that people live in. She gave bicycles to the children, and they had a playground. That was it. They had a huge reduction in school absenteeism, a reduction in asthma, reduction in headaches, reduction in abdominal pain, and improvement in their test scores, just giving them a safe playing environment to interact with their colleagues. It's pretty inexpensive, and it works way better than any later health efforts. So back in the early days in my career, Muhammad Yunus, in 1995, he was a rheumatologist who, studying fibromyalgia, identified that fibromyalgia occurs with a lot of other conditions. This is a later publication which identifies a whole host. These are the stuff we see in primary care practice. This is the bread and butter pain complaints that we see in our patients. Notice that Ptsd is on that score at the 11 o'clock position. This is the dreaded positive review of systems where the patient says everything hurts. I consider that a very helpful diagnostic determination, because if everything hurts, your pain system is broken. Easy. Now let's fix the pain system that's broken, and then we can go to root cause. And if you chase each one of these into the dead ends, you can do lots of surgeries, lots of procedures, a lot of unmet expectations, a lot of hopelessness, despair, and a lot of drugs and costs. So one is recognizing this, but this has been recognized by poets years ago. A quote that I heard at a talk I borrowed: "The sorrow which has no vent in tears may make other organs weep." I think that was so well said. Not quite as poetic as we heard earlier, Dora, but nonetheless my best effort at communicating, because this is where it's at. When your brain is on fire, I can't help your pain. Another way of putting it. And I pull this off all the MRI scanning that we're looking at, and they're all colors of fire. And the hotter the activity in the brain, the hotter the fire colors that are chosen. And I had a woman who we quickly determined had severe childhood abuse and neglect. Came in with Ehlers-Danlos syndrome, even though she didn't. She had 10 people who said she didn't have it. It was on her diagnostic list. And I didn't know where to begin. And I said, "I think your brain's on fire." She sat up, looked me in the eye, and at the end of the visit, she was literally huddled up in the room, wouldn't make any eye contact. At the end of the visit, just acknowledging that I understood what was wrong with her, she hugged me at the end. And it was all about male sexual abuse issues. She had an awful story. So she's going through that treatment. She's off all her opiates. She came in on high-dose opiates and benzos. She was a total mess. And it's taken 4 years. They don't untangle these problems easily, but you got to stick with it. And I tell you, I have cost the university, just the lack of reimbursements for the time I spent, easily $100,000, because I just spent a lot of time with her. I'm the boss, so I can make exceptions. But I can't let the system work as it's currently set to be able to provide that particular kind of care for her. And she's been bouncing around in community health psychology programs. They're all good, but there's so much turnover that she has to tell that same trauma story again and again and again and again, and she won't go back. So I can't get her back into behavioral health. We finally found a social worker over at Harborview who's now engaged in an effective way with her. So how did the drugs work? How am I doing for time? I'm all right? Oh, okay, good. Chronic pain treatments, the best we know for long-term care is 30% reduction in pain intensity That's how you get the drug approved. So when you see 30%, that means that's what the FDA required the experimenters to demonstrate. There has been essentially no studies on chronic opioid use because you only study for as long as it takes, and 3 months is enough to get through the FDA. What we do know is that a huge risk of harm. It's contraindicated in any brain on fire conditions because of the descending inhibitory pathways and the loss of your brake function. So at best, it's 30%. All the non-opioid drugs that we use, the gabapentinoids, the antidepressant category drugs, there's not a single drug treatment that improves on overall measures, pain intensity or function, and a whole host of other measures. So none of these studies were done comparing opioids to. Not a single study has been done to do that. But just looking at the data output on these studies, we really have pretty awful treatments on the drug side for almost all the chronic pain conditions we see. Now let's get a look at the rest of the things you guys are going to be talking about here today. CBT mindfulness, at least 50% reduction in pain bothersome. This was published just 2 years ago. So I'm waiting, and this audience may actually have seen it. I've yet to find one in 5 years of asking this question. Has there ever been a reported overdose of mindfulness? I'm waiting. You can call me in the middle of the night because I'm going to be the first out on this one. But exercise, TENS units, acupuncture, sleep restoration, hypnosis, manual therapy, and yoga and Tai Chi, the qualifier in that, it hasn't been adequately studied. So when we review the data, we need high quality evidence, there need to be tight controls, and you also need funding for a study. So a yoga study, if you did it properly, would probably cost $8 million. So I'm sure, Dora, you're going to contribute the $8 million to get this studied.
You also need standardization of teachers.
Standardization of teachers, yes. Yeah, a properly done study is extremely expensive. So the reason these numbers are so poor is because no one studied them. And in my practice, and many of you who are doing this kind of work, you can see these are powerful treatments. And there's now a push forward to get these properly studied. There's some money out there right now driven by the opioid epidemic, and we're grabbing for every nickel and dime that we can get to be able to study these properly at the university. But this is the next step, is validating and adding to the short list I have on the right. So non-drug pain treatments, this is sort of standard textbook stuff. Get your patient moving. Movement is medicine. Exercise is the miracle drug. I mean, we use all these terms, and it's true. We now begin to understand it. Massage, acupuncture appear to release endogenous anti-inflammatory molecules. One is called Resolvin. It's kind of a cute name. But moving muscle planes, like with yoga, like with acupuncture, when you jiggle the knee, releases both a growth factor that improves tissue recovery and also reduces pain by an anti-inflammatory, which has nothing to do with the COX system that we use in all our current anti-inflammatory. So this is 3-year-old data. We're just beginning to understand how the physical function and activity. Assistive devices let people do the things they need to do. So if you can't do something, if you can get an assistive device to help you do it, you'll be able to do it. You'll get meaning and purpose back in your life. Bending and learning techniques for people to pick up their grandchildren. Posture, strengthening core muscles. People don't use them. All the stuff that our physical therapists do. This improves function. Function improves meaning and purposefulness. Meaning and purposefulness puts the brake on our pain system. It's that simple. It's hard to do. We're not set up to do it. No one's paying for it, and we don't have a research background to justify this. Psychological and behavioral counseling, you're going to hear quite a bit about that. I just want to call out sleep hygiene. That's my #1 target. First thing I need to do is help. I've never met a patient referred to me for pain that sleeps well. We now understand there's a system called glymphocytes, glial cells that mop up the waste products that are generated during a daytime activity. And if you don't get 7 or 8 hours, the glymphocytes don't have enough time to pull that out, and that sensitizes the brain. Brain on fire. Again, a metaphor that actually works. So Before the electric light bulb, how many hours was customary for humans to sleep based on 18th century data? 10 hours was the normal. How many hours? I asked the students. I went 10. One person said she gets 10 hours of sleep. I was concerned about it. But then 9, no one, 8, no one, 7. We had a few hands, 6. We got to under 5. And there's been studies done on 5 hours or less of sleep. All your pain testing in an acute setting is doubled. Threshold, sensitivity, heat, cold, pressure, everything is doubled. So you got to get your patients to sleep. Now, your mind's racing, you're distressed, you're depressed, you're anxious. The pain sensations are difficult. So sleep hygiene, and the best treatment for sleep hygiene is cognitive behavioral therapy for insomnia. It works better. It's more durable than any other drug. And we know that after 30 days, all the sleeping meds that we give people stop working, and you get tolerant. And they interfere with the descending inhibitory pathway. And sleep architecture gets ruined also. So the architecture of sleep has to be maintained as well. Neuromodulation techniques, TENS units, spinal cord stimulation, DRG stimulation. There's a lot of other non-drug treatments for selected cases where they may work. TENS units are great. Karen, no, I'm sorry, I'm blanking on her name. A physical therapist, when I asked her, where do you set the TENS unit? She says about a fist above the level where you think the pain's being generated from. And I said, what do you set it at? High. And she's doing it with exercise. So she has people doing treadmill, getting their exercise, and they can't do it because it hurts too much. You put the TENS unit on above, and you just put all this other signaling in. And what does that activate? The descending inhibitory modulatory systems. That's what the spinal cord stimulators do. So we all coming back to the same common denominator. Integrative medicine, you're going to hear a bunch about that. And actually, we do a lot of work with our Bastyr colleagues. You'll be hearing later from a naturopathic perspective. But dietary hygiene fits into that. Yoga, Tai Chi, these are considered alternative therapies. I asked the director of the integrative, brand new, this started this year at the NIH. They have a Center for Integrative Health. And I asked her, so what makes cognitive behavioral therapy conventional medicine and mindfulness-based stress reduction complementary medicine? And she says, because it's not standard practice. And so someone in the room, a young investigator, said, so as soon as it's done regularly, she says, it's not integrative medicine, or it's standard practice. So we just need to shift it by doing it all the time, and we could change the definition. And we do it by making referrals, by having access, by having insurance payments. And spiritual counseling, I've said plenty on meaning and purpose. I just can't understate. Again, I'm going to pick on Dale about OB. It hurts a lot to have babies. There's no question about it. Any woman in the room will know that. But what do you get at the end of that process? You get a new life. It's the greatest thing in the world. Meaning and purpose. That's why the human race continues. And what system is activated during childbirth? The descending inhibitory modulatory systems. So it just gets back to that same common denominator. The drugs we use include NSAIDs, antidepressants, anticonvulsants, opioids, and local anesthetics. I put this up here not because it's a medically inclined audience, and I want to walk through all those drugs. But those of us who do the prescribing of the drugs need to understand how they work. Every one of these is poorly understood. We just figured out how NSAIDs work. They reduce the sensitization of the peripheral nociceptor, so it only works in inflammatory pain. We're still not sure where the gabapentinoids work. We have no idea where the other anticonvulsants work. We do understand where the tricyclics work. And interestingly, the tricyclics and the gabapentinoids work in the descending inhibitory pain pathways. So we get into the single, and that's the gate control theory. You probably all heard of the gate control theory. That's the gate. That's the descending, and we have functional MRI of spines right now, which show activation of the inner neuron beds that shut the gate. So it's not located in one spot in the brain overall. So pain is a team activity. Some people call it team sport. I don't think it's sporting at all for anyone involved in pain. But there's a lot of people, and getting all these people in the same room together, coordinating care, getting billing organized for that getting the service line organized for that is a near impossibility. Isn't that right, Dr. Stanos? You can do it. It's against all odds to be able to pull this kind of team together. But in such a complex system, it is essential that you consider all these domains. And I put chaplain here because we actually have a chaplain on our services at Harborview. And it's not because we're giving them last rites, because they've died of their trauma, but because when people feel that their life is ruined by the severe injury, spinal cord injury, like finding meaning and purpose in their life is incredibly effective. They've been able to reduce the opioid. Let me come back to questions in the back. Just keep a note of that. And I promise I'll get back to you. We've been able to reduce overall opiate prescribing at Harborview by 40% by adding an interdisciplinary team. Huge. We don't have it published yet because I don't have enough research money to get the publication going, but it's just dramatic. By the way, we're using mini acupuncture stickers in the neonatal ICU at Seattle Children's. Acupuncture was demanded by the parents, so they said, all right, we'll do it. We're going to lose money. It turns out they're making money on acupuncture at Seattle Children's. And they're putting it in NICU patients because the parents don't want their neonates to be doped up. They're on ventilators. It's pretty awful, so they got to keep the kids moving a lot and squirming and suffering from the techniques. And just the wiggling, they've reduced sedative and opiate drugs by about 50% in that population. So is it studied yet? No. Why not? Because it costs money to do the research and get the team all going. So we are at the beginning. The hope here is we're at the beginning of being able to recognize all this. So diagnosis, we got to make the diagnosis. Is there an indication for pain? For the sake of time, I'm going to give you the pain scale here, which is somewhat interesting, which is useful for acute pain. But if you ask the patient how much it hurts, we heard that earlier, Dora, of course it's going to hurt more. That's been now demonstrated. We understand why. So that's why we're not recommending even asking. I don't ask any of my chronic pain patients how much it hurts. I ask, how's the physical therapy going? How's your function going in general? What did you miss out on because of your pain? What are you doing that really gives you personal satisfaction? That's the opening line. And then you don't get in this pain intensity conversation. And notice that VA scale here, I've blown it up, nothing else matters. That's meaning and purpose question. So 10 over 10 pain. And what about 12 over 10? That means we're not listening. The patient's shouting. So we give them a 10, 0 to 10, and they don't think they're listening, they'll give us a 12. I did have a record. I had 20 million 2 weeks ago. So my answer was, I guess you don't think you're being heard. And that was amazing because that was what he was saying. And I knew the answer to the 20 million. So you can just say, I guess you're not being heard. So tell me what I need to know. And I spent the visit listening. It was amazing how effective it was. So whatever I recommend now is going to work, including all the techniques and strategies to proceed. So we have a couple of tools called the PEG tool, which I want to highlight. The E and the G is how much does pain interfere with your enjoyment of life, and the G, how much does pain interfere with your general function. This is now recommended by guidelines. We have lots of mood disorders that we need to review in detail, and we need to evaluate your behavioral health, distress caused by pain. If you're not distressed by having pain, if you're not distressed by losing your job, if you're not distressed by having no social interactions, you've been lobotomized, or you've been taking too many opiates and benzos, one or the other, because this is distressing. We have to acknowledge that this is critically important, and we need to track it. We have a 4-question item. I'm going to go fly through these to get through the conversation because I'm usually talking too much, as I usually do, but we'll get there. So here's our 4-question PTSD screener. You'll all have the slides to be able, for those wanting to take notes on this afterwards. This is the critical 4 questions. Nightmares is the one I use as the start off, but we give this as a questionnaire, paper questionnaire before we even see the patients. We have our fibromyalgia screener. We check these tools in our clinic. I'm putting this up here because you can develop, these systems are available. Our 88-question screener done online takes 11 minutes for the patient to fill out, and they do it at home before they come in. So I can start by saying, looks to me like your brain's on fire, as my opening line, rather than have to spend an hour reliving the entire horrible pain story again and go nowhere at the first visit, and you're just the same thing as everyone else has done, and they don't come back, and we have to restart the whole process again. So what can the medical profession and healthcare systems do? We need to overcome the system barriers. I alluded to some. There's lots of work going on, too little time, not enough pain-trained non-physician experts. There's a shortage of pain-trained physical therapists. There's a shortage of pain-trained psychologists. There's a lot of physical therapists, but they do sports injuries. But for chronic pain, there's a shortage because it's stigmatized in those fields as well. And we need financial incentives to do the stuff that we need to do as well. We need to avoid over-prescribing, because if you're on opiates for longer than 3 months, 65% chance you're on opiates the rest of your life. I'm opening my eyes big, because that's an eye-opener. That's something we can tell our patients too. If you're really on these opiates for 3 months, you may be on these. It's going to be a battle the rest of your life, because they change your neuroplastic central nervous system. So we are doing some work in collaboration with Group Health, Mike Parchment Group Health, our family medicine department. We have a system, it's called the building blocks, and notice it's system-focused. Consensus, leadership, ability to prepare for complex visits, not the 2-minute session that we ordinarily have. And then we need to understand the goals. We as clinicians need to understand the goal. Health systems need to understand what the goals, that we're not talking about relieving the pain intensity. We're talking about function, skills, attitudes, facilitated social interactions, and certainly opiates as the sole treatment for chronic pain will fail to meet these goals, as we have seen. John Lozier, palliation without rehabilitation to a patient with chronic pain and a normal life expectancy is a dangerous clinical, economic, and ethical decision. So yet again, so what people with pain can do, those who are struggling, you got to know about your pain condition. We know that self-management is the #1 treatment for managing all chronic diseases, diabetes, hypertension, cardiovascular. Pain is on the top of the list about being able to self-manage. Set reasonable expectations, stay motivated, and again, physical activity, regular rehab, any kind of activity. I'm big on yoga. I'm recommending for every one of my patients, by the way. You'll be happy. Connects the motor, the sensory, and the autonomic nervous system, the 3 systems that are involved in the pain experience, and take medications only as prescribed, and of course do not share. So summary, why is pain so hard? It's just really, really complicated. And we have to recognize, acknowledge the complexity of pain, and implement the strategies that we know. These are not things we don't have ready at hand. They're just not available and overall accessible. So those who are in clinic and don't know what to do, you can call our hotline. If it's an opiate-related issue, and we have a telepain program which has a psychologist, a psychiatrist, a rehab physician, an anesthesiologist, and myself in the room. It's our telepain program. Telepain, happy to present your cases. It's for clinicians who are taking care of patients of all specialties. And I'm going to close because I think I've already said this. I want you to note the date that this is attributed to Voltaire, 1850. Doctors pour drugs of which they know little. Amen to that. We just figured out. We still don't know how these drugs work. For diseases of which they know less, we are a little better than Voltaire's age, but it's not common knowledge yet. Everyone in the room gets this. Into patients of which they know nothing at all. And that's I would conclude the secret of the care for the patient is in caring for the patient. Francis Peabody, a surgeon, shockingly, a surgeon recognizing this, they do a medical student class. But you got to care. Their nervous systems are sensitized. So if you give a nod or you look disinterested, they can read your mirror neurons like any patient. It's like a child who can tell your mood, or the cat, or your pet dog. Our patients with chronic pain are so sensitized, they can feel every little emotion you're having. So you've got to express caring. That's the magic sauce to make this work. And again, John Lozier, chronic pain is not a state of opioid deficiency. Thanks very much. I ran out of time. I will speak separately for the question. Do I have time?
So that was so fantastic. Thank you so much.